welcome to our initiative of the All Indian Physician of North Ohio for the COVID-19 upcoming webinars via Zoom. It's my pleasure actually to introduce Dr. Neil Mehta. And the one introduction I'll give for him that I was his intern and I know him since then. Dr. Mehta is accomplished. He's the guru of informatics. He has started the medical informatics actually in Cleveland and in Northeast Ohio. He's the Associate Dean of the Curriculum Affairs at the Cleveland Clinical Learner College of Medicine of Case Western Reserve University. He's the Jones Day Endowed Chair of Medical Education. He has been very actively involved with the All Indian Physician of North Ohio. He was our past recipient of the Physician of the Year Award. And this year, I didn't give him a choice. I wanted him to chair the session of our CME for 2020. And it is co-chaired by Dr. Vikram Kumar. And here I welcome Dr. Neil Mehta.
Thank you so much, Rupesh. And thank you all for coming and joining us. It's a pleasure to be here. And I see quite a few people have made time to come here. So one of the challenges for this presentation is that we have a pretty mixed audience. And what both I and my Dr. Mukunda, who follows me, are going to try and do is keep it at a level that will be of interest both to clinicians and those who are not clinicians. And we are going to give you ample time for questions at the end of the presentations in case you have them. So I'm going to turn off my video and then go in and share my slides here. And like I said, very soon after this, I'll have about 10 to 15 minutes on talking about masks. And then soon after that, I'll be talking about ACE inhibitors and ARBs, and we'll have questions. And then we'll go to Dr. Mukunda. So I got lucky, I guess, to get two very controversial topics to talk about. The first topic is about masks and the role of masks in COVID-19 infections. So why is this controversial? And I personally think that the biggest problem that happened with masks was the very poor messaging by the WHO and the CDCs about the role of masks. So what do I mean by poor messaging? So first of all, both organizations and almost all the experts kept saying masks don't work to protect you. While that is somewhat true, I think at the end of this presentation, you will realize why it was poor messaging. The second thing they did was stress the fact that if you start buying masks to protect yourself, you are going to use up all the masks, which should be reserved for the healthcare worker. So immediately there was confusion that if the masks don't work for me, why would they work for the healthcare worker? And they didn't really try and explain that. Two other messages came out a little bit later. First was that asymptomatic people do not give you infection. And what that means is that there is no benefit to wearing masks for the general public, that there is no need for the average person walking around in the town to wear a mask. So let's take a look at a few concepts. And the first one I want to talk about is that you mostly know this, that there is the N95, which is the respirator, and it is the highest level mask that is commonly available. It blocks 95% of viruses. Then is the surgical mask. And then the one that we're going to talk about is really the cloth mask or the homemade mask. So I want to be clear that we are talking about homemade masks during this presentation. These two are still in short supply, and these are reserved for healthcare workers, and we are not going to contest that. The other myth that was existing was that the masks, either cloth or surgical masks, because they are not as good as the N95s, and they are not 100% effective at preventing droplets from coming in, that there's no point wearing them. And I would like to contest that it's not a question of yin and yang or black and white. It's not 100% or nothing. Actually, the amount of viral load that you get when someone coughs or sneezes matters. If you get a very low viral load, your immune system can react to it and control it. This is true of all infections. And if you get a very huge viral load, like the physicians who are intubating patients, that's when the immune system cannot fight it, and that's when it leads to infections. Also, how long you are close to someone and how close you are to someone also matters. And this is part of the principle of social distancing. So the big WHO statement was that the masks don't protect you. So this guy here is wearing a mask, and why do you think he's wearing it? Well, this person has infection, and he is wearing it to protect himself from the person who has infection. The real reason to wear a cloth or a surgical mask for an average person is actually this. If you have no symptoms, but you are a carrier, meaning you have the virus, if you wear a mask, you are actually protecting this person. And that is the concept we need to keep in mind. The other concept is the concept of how the virus spreads. So here is a person who coughs, sneezes, yawns. Every time you do that, a little bit of respiratory secretion is emitted from the mouth. Now, immediately, the drops that come out are pretty big. As they are still small, but they are pretty big compared to the very small micro, less than 5 micron particles. These evaporate and they start becoming smaller. So right here, you have really big particles and they will start getting smaller as they go further. The ones that are bigger, that are usually actually, this says 10, but it's really the 5 is the cutoff. If they are more than 5 microns, gravity gets hold of them and they drop. The ones that are really small, that are less than 5 microns, tend to float and they will just float in the air. So these ones that fall to the ground are called droplets, and the ones that keep floating and are really small are called aerosols. And what we know is most of the transmission of COVID happens with droplets and not with aerosols. There have been some studies about aerosols. They are only in experimental settings and have never been shown to transmit infection at longer distances. So keep all this in mind as we move forward. So couple studies, I'm just going to look at them at a very high level. So here is a study that shows the viral load on the first day of symptoms, and they continue to measure the load at multiple times throughout the course of the disease, all the way to 3 weeks. And what you notice immediately is the highest viral load is on the first day. And if you extrapolate this backwards, most likely the graph kind of goes something like that. And so the highest peak of the viral load that a person has in their throat and nasopharynx is actually before they get symptoms. Secondly, this has been shown now from multiple cases, the study from a village in Italy, the study of the cruise ships, 44% of people who have the infection have no symptoms. And what that means is most of the transmission is happening in the pre-symptomatic stage. So now we are faced with this quandary. We have the highest viral load at the time when there is no symptoms, and a lot of people are asymptomatic. And every time they cough or sneeze or yawn or speak, droplets are coming out. So let's take a look at a video. And the video is of a laser light being reflected off of droplets. And in the first part of the video, the person is not wearing a mask and he's just speaking. So he keeps saying a word like health, something with TH, which makes you usually spit more droplets. And then you will see in the second half of the video, there is a mask on. And what you're looking for are the number of green droplets. The more the droplets, the more the respiratory secretions. So let's start. The first part is without a mask. And you will see this is a person speaking, and you see the green dots. And now he puts on a mask, and he's still speaking. And you literally see hardly one or two dots at all. And this was in the NEJM as a way to prove that a regular cloth mask blocks most of your droplets from being emitted. Yeah. So then one other study, I want you to focus on the part here, okay? So what we have is on the y-axis, the viral count of droplets carrying viruses that was collected by a device. And here are droplets in a person without a mask, and you can see how many droplets there were. With a mask, there is hardly any droplets at all. This is aerosols, a lot of droplets without a mask. With a mask, almost no. And again, this was with a surgical mask. So you'd say, well, we were talking about cloth masks. Why are you showing me a slide of surgical mask? And the reason I want to show that to you is this study in the Annals, a very prestigious journal, 4 patients. Each patient is one column. And I want you to look at just this part of the table. So the first line is a person coughing without a mask, and the numbers reflect the viral load, okay? So you can see in the first patient, it's 3.5. In the last patient, even though he's coughing, there's no virus. Then you wear a surgical mask, and it's actually less than the without a mask. But the best data is with a cloth mask. The lowest number in a person who wears a mask who has COVID are with a cotton mask. And it's better even than a surgical mask. Remember, this is data for a person who is wearing a mask to prevent transmission, not to protect himself. There is very poor data for people being protected by these masks. One other concept I want to make sure you get is something called R naught. So it's written like this, but it's pronounced R naught, and it's called the reproductive ratio. So think about this. There is a patient who is the first patient to get a disease. If each person gives the virus to 2 more people, and that goes on, as you can see, the R naught is called 2. And if the person would give it to 4 people, you can see how fast it spreads and how widely it spreads. That is called an R naught of 4. What you want is an R naught that is less than 1. If you get an R naught that is less than 1, the pandemic dies because very few people are getting infection and fewer people are getting an infection than those who have it. That is what happened with the original SARS. It died because its R naught was very low. So one busy slide coming up, and just bear with me here. So this is a model. This is not a study, but imagine that more and more people wear a mask. That's on this axis. And the more effective the mask, it's on this axis. All right. And now look at what happens. If you're wearing a decently effective mask, 60% effective, and almost everyone wears a mask, you get into this zone here. And that is the blue zone. And that means your R naught is less than 1. So essentially, if most people, not everyone, wear a mask that is somewhat effective, we can actually control the spread of this pandemic. And the biggest question we have right now is we have this lockdown, we have zero economy. How are we going to start loosening? And part of the answer may just be that we need to make sure everyone wears a mask without stigma, and it is to protect others and not to protect themselves. And the way to think about this is the precautionary principle. So when the scientific matter and the knowledge is not 100%, what do you do? And you look at whether the intervention or the treatment is expensive and whether it can cause harm. And if neither of these are true, it is worth trying the intervention, in this case, a mask. So that is my last slide on the masks. And if you have questions, you can either put them in the chat window, or we will have time towards after my second presentation to talk about that. So, oh, and I forgot this. This is critical. So this was just a natural experiment. So I said there's not much data. The only thing we have is natural experiments. And what we have is the countries that the public wears masks. And you can see Hong Kong, Singapore, Japan, and South Korea are doing much, much, much better than the countries that did not have a mask policy. Now, there are many reasons, other reasons why they may be doing better. That's why this is not 100% proof, but it also makes a case for why people should wear a mask. Okay, deep breath. Change in gears completely. So forget everything we talked about masks. And now we're going to talk about two medications that have caused tremendous controversy in COVID. And these two medications are, this one is full form is angiotensin converting enzyme inhibitor. And this one is angiotensin 2 receptor blocker. But for short, we call them ACE and ARB. Okay, so that's how we're going to refer to them. Now, why are these important? You probably all know people who have high blood pressure, heart diseases like heart failure, diabetes. These two medications have been shown beyond a doubt to improve outcomes. People who take these medications have fewer complications and live longer with these conditions. So these are very, very, very good medications. So you'd say, you don't know what these are. Well, the way you recognize them is by their name. So if you know a medicine that ends in pril, that's an ACE inhibitor. If you know a medicine that ends in sartan, that's an angiotensin receptor blocker. And if I took a vote, I would say almost every one of you either takes one of these or has a first degree relative who takes one of these. So that is why this is so important. So the controversy here is, are these agents bad in the setting of COVID, or are they good in the setting of COVID? And let me explain that question a little bit, but this is really the question we are trying to answer. So why would it be bad? So the COVID, this here is the COVID coronavirus, and it has these things which are called the spike proteins. And they attach to this receptor here, and the receptor is called ACE2. Okay, remember ACE2, it's going to come up on the very next slide. So ACE2 is how the virus attaches to the cell, and then this allows it to get inside the cell. That means if you do not have any ACE2, you cannot get COVID. And if you have lots and lots of ACE2, the question is, are you more susceptible to COVID? And that leads to the second point, that in animal studies, both ACE inhibitors and ARBs show that they increase the level of ACE2. And we just saw that the question is, if you have more ACE2, are you more likely to get an infection, and whether that infection could be worse? So if you're taking an ACE or an ARB, you're probably sweating right now and saying, what do I do? So hold your breath. Because these agents can also be good. And pardon me for this somewhat complex slide, but this is critical. So there is a chemical called angiotensinogen that becomes angiotensin 1. And there is an enzyme, this here, angiotensin converting enzyme, which converts it to angiotensin 2. And this works on the receptor. And when it works on the receptor, it does a lot of bad things. It causes vasoconstriction, hypertrophy, scarring, proliferation of the smooth muscle, atherosclerosis. All these things are bad for your heart. And these have been shown that in people who have lung infections or pneumonias, there is very high level of angiotensin 2. And this is what is considered to be one of the key reasons why people get severe lung injury in cases of infections. Even with Ebola and influenza, this was shown to be the cause of why people died, or part of the reason why people died. Now, here is ACE2 again, the very same thing we just saw right here. This is ACE2. So ACE2 actually takes away angiotensin 2 and makes it into something else. This something else works on another receptor that does the exact opposite thing that angiotensin 2 does. So remember, angiotensin 2 is bad, this is good, and it does all the good things for you. So now you have something that ACE2 is actually a good thing. And ACE inhibitors and ARBs, they work on this pathway to decrease the effect of angiotensin 2. So these agents are good for you because they decrease the level of angiotensin 2 working on the receptor, and they increase the level of ACE2. So now we have this issue that these agents are either bad or they are good, and we need to figure out what the evidence is. So this is the big question. ACE inhibitors and ARBs are critical medications for these conditions. And I want you to remember them. I call them comorbidities. And if I ever say that, that means I'm talking about these types of diseases. And the question for us is, are they good for you? Are they bad for you? Should you stop them, start them, or switch them? So you'd think, gosh, with all this data, this should be easy to answer, right? But it's not, because we know from all the data from China that these same conditions are what cause people to die. So these are the ones that cause people to eat. People with these conditions have higher risk of dying, ending up in the ICU, ending up on a ventilator, all right? So if you are also treating them with this condition, medications, when someone has death or ends up on a ventilator, you don't know it's because they have these conditions or because they are on these medications. And this is called confounder, okay? So it is not easy to test this because even if you find that people on ACE inhibitors do badly, you don't know if it's because of the ACE inhibitor or because of the condition it was being used to treat. So I hope that is clear. Bad diseases cause bad outcomes. ACE inhibitors and ARBs used to treat these diseases. If someone does badly, is it ACE ARB or is it the diseases themselves causing this problem? So I don't expect you to read this slide. The reason I want to show this is there has just been 7 studies so far out of the 600 or 6,000 that have been published on COVID on looking at ACE inhibitors and ARBs. And most of them are pretty poor. I'll run through a couple real quick. This study here had only 10 patients on ARBs. Another study, 37 patients on ACE inhibitors and only 9 patients on ARBs. This study was much better. It had quite a few patients, but it had a huge bias because physicians could decide who to start ACE inhibitors or ARBs on. And I can talk more about these if there are physicians in the audience who have questions about any of these studies. And probably the best study of them all was done at the VA. Bigger numbers, 40% on ACE inhibitors. What they found, and remember, this is unadjusted. What does unadjusted mean? That they did not account for the confounders, the comorbidities. So they just looked at, do people on ACE inhibitors do worse or not? And yes, they did. 50% versus 37 hospitalization, 21 versus 9 ICU, 3 versus 1 death. But when you adjusted for the fact that they had all these bad diseases, there was no significant difference. So after all this, basically we have no good data whether ACE inhibitors and ARBs are good for you or bad for you at the point of this conversation. There are studies on this coming out every day right now. So what we have reached is something called clinical equipoise. And I love this word. What it means is that we have reached a point where there is truly, after a lot of attempts, uncertainty about whether a medication is beneficial or not. And the only way we can find out is to do a clinical trial. And you can do it ethically because we have tried our best to answer this question without making people choose whether to, or giving it to one person and not giving it to the other. If we knew it was clearly beneficial, you would never be able to do a trial. So the bottom line is we don't know. These agents could be harmful, they could be protective, or they could be neutral. What I would tell you is at this point, do not stop these medications or tell your relatives not to stop them, because withdrawing these medications can also cause serious harm. And the best thing we can do is wait for bigger data sets or wait for outcomes of clinical trials. So I'm going to stop there. And Dharmesh, I don't know if we have time for questions.
Yes, we can take some questions now. Yeah. If anyone has question, you can ask now. And then you can unmute yourself and ask the question.
Dr. Mehta, hi.
Hi.
Yeah.
This is Dr. Goyal. Thank you for the wonderful presentation. What about NSAIDs? Is there any data about NSAIDs? There have been some studies coming out. You know, if you take Motrin or Advil, you have a high risk of mortality. Is that true or just a?
Yeah, great question. Obviously not directly related to the talk, but this rumor or the information came out of the trial from France, and what they saw was a few young patients, and the young patients normally don't end up having bad outcomes. You know that. It's really the elderly who do. And what they found was they looked back at what these young patients had been doing, and it turned out by chance that several of them had been taking high doses of ibuprofen because they had fever and muscle aches. And so they said that is probably why they got a bad outcome. And so they actually issued a warning that stop taking NSAIDs. That has been looked at in subsequent studies, and they basically have said that there's no need for a warning, but there is definitely need for a trial, or at least a bigger study. We at the clinic actually have a registry where we are looking at this exact question, so, and I'm sure other people are. So hopefully we may have an answer in a few weeks. As you lump NSAIDs, do not lump indomethacin with it, because there is actually potentially a beneficial role to indomethacin because it has antiviral property. Again, that is another study that is going on right now.
Dr. Mehta, this is Vikas. I have a question. Regarding the masks, or like a cloth mask, is it a guideline from CDC to recommend or mandate the general public for like a use for it?
Yeah, good question. So the CDC, and I know I'm being recorded, but I'll say it publicly, has been very, very, very slow with this, like I said earlier. So a lot of people were advocating universal use of cloth masks if you are not wearing PPE. And the CDC actually did not advise that. If you look at their current CDC guidelines now, and you look at most of the hospitals, they have a universal mask policy for all visitors and all healthcare providers who are not using PPE. So already the hospitals have completely shifted their stance. And when you walk into, I work at the Cleveland Clinic, when you walk into the clinic, they take a temperature and give you a cloth mask. You could be a patient, you could be a visitor. There are very few visitors, but some are allowed. You are just a transport person, you are an admin person, you are a front desk person. Everyone wears a cloth mask, and that is a universal policy. The policy for the general public, still, US is not there as far as I know. But if you look at a lot of European countries, now they are on board and they are making mask wearing in the public a requirement, and it's mandatory. And a lot of the East Asian countries, like in China, there were drones on the street that would be taking your photo, and they would tell you that you need to wear a mask or you would get a penalty. So long answer, I have a feeling that to come out of this pandemic, a lockdown, it's very possible that in addition to hand washing and keeping your distance, wearing a mask, especially in areas like public transport, grocery stores, malls, is probably going to be the smart thing to do.
Neil, this is Pradeep,
Yeah.
and you know Snehata and Pradeep very well. And Dharmesh, thank you.
No problem. Thank
It's all in the family. I have a question. You talked about the ACE inhibitors, and you know I'm not a doctor, my Snehata is. So I'm asking one thing, is there any study being made or is it done already that if you are taking these medicines for a longer than certain period of time, it is either helpful or not helpful for this virus?
That's exactly the question that we are trying to answer. We are actually doing that study at the clinic too. But most signals are that there is not a single good enough study that is giving us an answer, which means maybe it is neutral, or we don't have good data because, you know, when people say the medication list says that he's taking an ACE inhibitor, that is just the medication list. You have to talk to the person to say how often they take it. Are they actually taking it every day and what dose? To do that for thousands of people takes a lot of time. And that is the type of study that you'll need to do to really prove that these things work or not. That is how clinical trials work. So the answer is we don't know. I would stay on these medications. There is a very distinct chance that they may be beneficial. A lot of nephrologists and cardiologists believe that it actually will be beneficial. We just haven't been able to prove it.
Thanks. Thanks, Neil.
Okay. We will like to move to the next presentation now. So thank you, Dr. Neil Mehta, and then we can take more questions after that.
Okay, we'll move on to the next presentation. It's my pleasure to introduce Dr. Beejadi Mukunda. And most of you know him. He's a director of the Department of Medicine, Hillcrest. He's a chief of the staff of the Hillcrest Hospital. He's a president of the AFG enclosure, and he's also a chairman, current chairman and past president of EPNO. And Dr. Mukunda is going to talk about COVID-19 update to give you the evolving trend, what's going on, and we are learning as the time passes. So this is pretty relevant topic for the medical person and general people. So I welcome Dr. Beejadi Mukunda.
Thank you, Rupesh. Thanks, Dharmesh, and great presentation, Neil. How to follow in your footsteps, but I will do my best. My presentation, I'm going to focus a little bit on newer developments, mostly from the community and public health focus, along with the things that Rupesh mentioned. I'm also having the opportunity to work as a medical director with the CareSource. And there is a lot of work that is going on behind the background, trying to reopen Ohio. So I'm going to focus a little bit on that. Charles Darwin said many years ago that it's not the strongest of the species that survives, nor the most intelligent. It is the one that most adaptable to change. So since change is going to be inevitable, there is a lot of effort that is being put in this regard. So this was one of the recent presentations from Mike Devine's office. So if you look at this, this is the playbook for the path forward after a pandemic. So essentially, this requires a great deal of public health measures and compliance. Just because there are measures that are recommended, if you don't comply, it's not going to work. Businesses operating safely with safeguards, and that would be the key. And what type of businesses are going to open, what are going to open later, that will be all directed by the state. And protecting the most vulnerable. And that's where we need to focus a lot in community health. How do we protect the vulnerable population? And if you look at the privately operated the congregate living facilities, these are just another name for long-term care facilities or post-acute facilities. These consist of many different types of facilities. Usually we think of nursing homes, but there are assisted livings, there's residential care facilities, there is the Ohio Department of Medicine licensed treatment facilities, substance use residential treatment facilities, etc. And this was kind of a shock to me when I saw these numbers. The long-term care facilities in Ohio alone, there are 978 skilled nursing facilities, 774 assisted living facilities, 436 other residences, and there are 152 state licensed hospice agencies and 770 home health agencies. So you can imagine the amount of education and the training that needs to be done with all these varieties of workers and the residents that are in these types of facilities just in Ohio alone. So there is a lot of data that is being collected in the background. This is kind of a busy slide, but I just want you to focus on the way the data is collected. If you look at the rightmost corner, it shows the size of the gray circles, which go from null to more than 21. And that just indicates across the map how the number of cases that are infected and that are hospitalized are kind of distributed. So to go forward, there's going to be three very, very important players in terms of the healthcare. These are going to be hospital systems, local health departments, and facility or community partners that are the nursing homes and the residential services and of course the physician practices. And this slide just skeleton framework of what these areas may look like. In Ohio, the governor has divided the state into 3 zones. And in Northeast Ohio, we are all in zone 1. There is zone 2, which is kind of in the middle Ohio, and the zone 3, which is like the southern part of Ohio. And within the zones, there are community hospitals, the local health departments, and the facilities. And there are multiple services that are aligned with each of these types of facilities. And a new concept that is coming up, and this has already been in existence in New York and New Jersey, what are called healthcare isolation centers. These are not hospitals, these are not nursing homes, could be an old hospital building that's not being used, that's going to be converted to this. These are essentially facilities where the people that are exposed to COVID-19 but are asymptomatic are quarantined and are there is a requirement, they require treatment for probable illness with isolation, but they are not very sick. And in terms of the incidence management, essentially meaning, how do we tackle this problem? There are all these what are called the pillars of the incidence management, which are team building. So teams are being built with the healthcare facility in the middle of the team. Dr. Robert Wiley, who is the Chief Operations Officer for Cleveland Clinic, is in charge of Zone 1. Similarly, there are physicians for Zone 2 and Zone 3. And there is the focus on transmission reduction, triage preparedness, targeted conversations, telehealth capabilities, test and treat in place, and transitions of care. These are all equally important. And in terms of the transmission reduction, we just heard the great talk from Neil. And Ohio initiatives going forward, this just came out from the state medical board that the reporting of cases, which is mandatory, and they have very clearly said that the providers must notify the local health department within 24 hours of confirmed or probable case identification. So if we see somebody and if we suspect they are COVID, we send them for testing. It requires us to report to the state. Does not include retrospective identification of probable cases. Updated testing guidance. All of this time, it has been, as if you've seen around, it has been quite difficult to get a testing done. And the reason for that, one of the reasons has been that there was a mandate from the Ohio Health Department and the health director that all COVID-19 tests in Ohio have to be analyzed by an Ohio hospital system. And now that has been taken off. So you're going to see this drive-through testing. I think there are 2 coming up in Rite Aid, where if you have an order from your physician, you can get an appointment by going to Rite Aid, the website, get an appointment, go there, and they will collect the sample and they will send you the results. So this type of testing is going to become more common now that Dr. Acton has rescinded the previous order. And COVID-19 testing in Ohio at this point is divided into 3 priorities or 4. So there's priority 1, who are healthcare workers and hospitalized individuals. And then it becomes less and less intense with priority 2, 2A, and 3. And in order to help the physicians to maintain their health, physical, mental health, there are multiple resources that are being put in place. As you know, multiple healthcare workers have been infected. You may have seen recently that in the Beaumont system, there were over 1,400 healthcare workers that were exposed and had the infection. So, these are going to be real once the social distancing and once more economic opening up are going to start. So these are some of the resources, and we can email this to you later. There are more from the Ohio Department of Health, CDC, well-being resources from crisis hotline, disaster distress helpline, suicide prevention lifelines, peer support for the physicians. There are ongoing Zoom sessions to help the physicians, and there are other public resources. Mental health resources, both for patients and healthcare workers. These are all being put in place more so because of the opening up of the economy and the problems that we may be facing soon. And wellness support. This is an area where a lot of the private organizations have stepped in. And you may have seen some of this Headspace, that is meditation, that is going to be free for physicians and other healthcare workers. If you go to the website, download the app, put in your name and your NPI number, they basically give you free online access for meditation, relaxation, all those things which otherwise would have cost money in the past. So those are about the public health. And if I have time, I will go more over the community health. But if you'd like to go ahead and take questions, I'm happy to do that.
This is Saroj Mahala. I have a question. Is there any shortage of masks in Cleveland area?
Hi, Dr. Mahala. How are you?
Fine.
So the question is, are you talking about surgical masks, N95s, or cloth masks?
Cloth and surgical.
Yeah, so cloth masks, as you know, most people are now making themselves. You can get them very easily, make them very easily. There are all these videos of how to make a t-shirt into a cloth mask. So I think the cloth mask shortage is not an issue at all. The surgical mask, we hear, obviously the hospitals tell us what they tell us. And it seems like there are some hospitals that still are short of surgical masks, and others do not have that problem. But remember, the way they use these surgical masks is if you are just seeing someone who is asymptomatic, someone who comes to see you for follow-up of their diabetes, has no cough, you do not wear a surgical mask. Surgical masks are worn in the inpatient setting and in the taking care of patients who have COVID. And then if you are doing anything that is going to involve aerosolization, that's when you use N95. So if you say, I want to use a surgical mask for every patient and I'm going to change it with every patient, I don't think that is enough for that.
Okay. Thank you.
Uh-huh.
I think there is a question from
Mr. Shah, do you have a question?
Mr. Shah.
Yes,
Go ahead.
Ramesh Shah.
Yeah.
Yeah, go ahead with your question, Dr. Shah.
Sounds it.
No, we can hear you. Go ahead and talk.
Yeah, just ask the question. So we.
What is the confidence level in vaccine being tested in United Kingdom? Is the basic concept very strong medically?
So I think, correct me if I'm wrong, I think Dr. Mukunda also chip in. I think the question is, will the vaccines work? Is that what you're asking?
Yeah, but they already started the testing to 800 patients as of yesterday. So I'm
Right.
sure he passed a lot of pre-testing before coming to this level.
Yeah, so, you know, the way vaccines have to be designed and tested is you start off by first thinking about what you're going to attack, right? So are you going to attack the spike protein, which is one area of interest for developing a vaccine? The other areas are developing monoclonal antibodies, which is a completely different thing. So once you decide you want to make a vaccine, you have to find a way, make a protein that when you give it, the body will make the antibodies, right? And then are those antibodies good enough to block the protein? And then will they be able to prevent an infection? And will they cause harm? Right? So you have to go through all this stuff. So they start off with animal studies. They've done those. Then they're testing the doses in humans to see if they are safe. Then they find the highest safe dose and see if they're developing antibodies, and then do those antibodies protect you. The last part of the trial takes a long time because you have to give it to a lot of people and wait. You have to wait to see if they get infection or not compared to the people who don't get vaccinated. There is also a very small risk of something that has been shown with other vaccines and other viruses, that actually the vaccine enhances the infection. That is called ADE. And that risk, you have to make sure that that risk does not exist with the vaccines that are being made. So a lot of testing to be done. Most people say it's 18 months away. There is one vaccine that they're developing in Boston, which is a deep intramuscular shot that they say will work within 6 months. And a lot of hospitals are trying to work with them to see if that can be tested.
Dr. Mukunda and Dr. Mehta, thank you for your amazing talk. One last brief question. A lot of the Indian community and non-Indian community in the area are elderly, potentially on anti-cancer therapies or have immunocompromised status of some sort. Can either or one of you comment on the risk of contracting COVID and what it could potentially mean to a person who has some sort of immune condition or is on anti-cancer therapy? Thank you.
Dr. Mukunda, you want to take that?
Sure, Neil, thank you. So, you know, the recent study in New York showed that about 14% of the common population is already infected, and they could be quite asymptomatic. So any interaction with even an asymptomatic person can result in an infection, and that's the importance of everyone wearing the mask, as Neil was suggesting, and also to keep the social distance. Patients that are having cancer that are active and also being treated with cancer treatment are definitely at higher risk. And the other issue that they face that we see commonly is that they have to many of the time go to the hospital or a facility to get the infusions and to get the blood work and all that. And unfortunately, it's very difficult for them to stay home and get telemedicine like many of us otherwise can get, for example, for high blood pressure, diabetes, etc. So since cancer treatment requires a lot of times the hands-on treatment, unfortunately, that exposes them also to high risk. Neil, your thoughts?
No, I think great points. I think what a lot of models for coming out of lockdown are including is that the most vulnerable would continue to be under lockdown while the rest of the population slowly comes out of it. And anyone with a history of cancer, even if they're not on chemo, are at high risk according to the studies. So we have to take really good care of the most vulnerable people. It's a great point.
To add into that, Dr. Mehta, I think the same is true for any transplant patients, especially the kidney and any solid organ and bone marrow transplant. So most of the visits are restricted and labs are monitored because they are also immunosuppressed. So it's the same, they come into the same category and they have the same concern. So we have to be very protective for them too.
Dr. Mukunda, I have a question. I read a statement from CDC that they are expecting a second peak sometime with overlap with the flu, and that may be more lethal, more dangerous. So whenever the lockdown is removed, what kind of restrictions do you expect? And what are your thoughts about the second wave coming in November, December?
That's a very interesting question. There are, as with every other question with COVID, there are two types of answers. Depends on who you ask. So one start from CDC, I think it was CDC, Dr. Redford, that said it's going to be more deadly once the flu starts, and it's going to be COVID, either the same one continuing or another wave of the COVID that's going to cause very deadly epidemic or pandemic again. But one other way that this has been looked at is because we are not shaking hands, because we are maintaining social distance, because we are washing everything and also wearing masks. And also people are not going to the hospitals and nursing homes, offices, where they may come in contact with other people that are sick. There is also a thought that actually the flu and RSV may go down next year. But making it even more complicated is the big concern from the state of Ohio right now and the pediatric physicians is you cannot do well child visits on telemedicine. As adults, we can do wellness visit, a lot of the office visits on telemedicine, but the well child visit always requires some type of vaccination, almost always. So many of these children may be lacking vaccination, not just the flu and others, but the regular vaccinations that they're going to get. So they may end up with a bigger wave of other illnesses, like what happened with the measles. So that's, again, something that we have to wait and see. But I think taking the usual precautions that we are taking is very important to prevent any other infection from popping up. Neil, your thoughts?
No, I think excellent point. And I think the absence of vaccination and even adults not following up, they even are talking about a second wave of the non-COVID illnesses. So all of us who see patients with chronic diseases, they are avoiding hospitals and they are avoiding routine care where we pick up problems early. And there is a serious concern that we may see the complications come out as they start coming back to see us. So, but otherwise, great points, Dr. Mukunda.
Thank you.
I
think
had
one
a question.
question that often comes up is, how can we help other than what we are doing on the front lines? I just want to thank all of you for keeping up with the good information and also contributing in terms of helping the food banks. I think that's one of the things that's going to make a big impact for the society. As people come out, they're unemployed, people are being released from the prisons. There is a big risk of increasing crime and violence in the society. and providing food security for not only for the adults, but also the children that don't have the midday meal at the school goes a long way in keeping the community healthy. So if you think of helping in one way, please look at the food banks and donation to the food bank. And you can certainly do that through APNO. And the others are, if you already had the COVID and you got better, you are in great shape to not only to volunteer for swab collection, contact tracing, etc., but also please consider plasma donation, which is another thing that Rupesh and Dharmesh are big proponents of through SEVA.
Any more questions anyone
Yes,
has?
I had one question.
Sure.
For Dr. Mehta. In hospital, we use different masks like N95, pepper, and capper mask. In your opinion, do they find any difference or any study regarding? Because we find that this SARS-CoV virus size is 0.1 micron and N95 size is 0.3 micron. So I was wondering, does it really protect, or how far we are protected?
Yeah, so a good question. I think the more barriers you have, the better, especially for aerosolized procedures where the aerosolization is involved. So, non-invasive ventilation, classic example, people who are using CPAP or high flows, people getting nebulizer treatments. So avoid nebulizers and use an MDI instead. But intubation, that is where you want to be as well protected as possible. And so even if you're wearing an N95, have a face shield in front of it. People are trying, you probably have seen those plexiglass boxes when intubating patients. Chirag is on the line, so he can tell us how difficult that would be. But a lot of people on the East Coast are trying that. So I think that all that means is if you can find something that will create even a better airtight barrier, go for it. That's really all I can say when it's a question of aerosolization. Even the N95 is only 95% good. So what about that 5%, right? So do the best you can and have as many barriers as possible between you for those procedures. The data for someone who is not getting a procedure that would cause aerosolization is not there. So if in that case, probably a surgical mask and a face shield is probably enough because that will take care of most of the droplets. It would be great if the patients wore a mask, but that is not the protocol in our hospitals.
I think the P100 masks are the best, the filters basically, not the mask. The P100 that protects 99.97%. And the pepper mask that covers the whole body, these are the best masks. And then the capper, and then the half mask respirators, and then the N95. So in the OR, we have been using half mask respirators. We have full mask respirators. Basically that has face shield built in. So if you can get P100 filters with any kind of mask would be the best, most protective.
Yeah, I think a good point that Chirag made. Sorry about the eyes. It's really, really important. COVID has been detected in eye secretions for several weeks. So again, you can get infection through it, and eye fluid is also infective. So just something to keep in mind. Sorry, I interrupted you.
I was just asking, is that D100 is a screen that can be used in capper mask or pepper mask, or it's kind of different mask at all?
Chirag, I think the question's for you.
I'm sorry, I couldn't hear you.
You're talking about the D100
P100,
screen.
P as in Peter, P100, those are the filters.
Okay. And can you put it on the capper mask or pepper mask, or it needs a different system at all?
I don't know, you can change that, but I believe you can. But you know what, I have bought my own, and those are, you can change after, because these are good for 1 month, 30 days, or continuous 40-hour use. So you can, if you have N95, you can change it to P100. These are all interchangeable.
Thank you.
It looks like a Darth Vader mask, so that's what he's talking about. Yeah.
Dr. Mukunda, I have one brief question. I know several people who have parents who live in independent living facilities, not quite nursing homes, but step down, independent, assisted living. Many of their children have taken these parents home. Can you comment as to what the official outlook is, or what your experience has been of people kind of returning to these facilities, and when it's a good time? Would it be June, July, August, or is this something dictated by the state of Ohio? Thank you.
Dr. Mukunda, you're muted.
Thanks for that great question. That's being addressed at various levels. The biggest drawback at this point is not having enough testing done. Though the hospital systems say that they have excess testing capability at this point, not everybody that needs a test is able to get a test. And as you know, there is about 14 to 15% asymptomatic infection. It would make sense to test somebody before they come back into the communal living. Otherwise, they have to be quarantined for about 14 days before they mix with others. And I think most of the assisted living facilities are not having group meals and things like that right now. They're all providing care in their own rooms. But there are anecdotes of various issues even in that setting. For example, recently there was an assisted living where every resident was asked to put a note in front of their door in the morning to say, "I'm okay," so that the caregivers are not spending too much time checking on them. It so happened a few of them put the note and then they fell. And they were not recognized until the next day because everybody was under the impression that these people are okay, let's focus our work on other people. So that's a work in progress. If they're already at home with children, it probably makes sense to keep them as long as more testing is available and a safe plan is put in place. Otherwise, a reasonable alternative is to go back to the facility and to maintain isolation or quarantine at least for about 14 days, because if they are infected, you don't want them to infect others, or vice versa.
Thank you, Dr. Mukunda.
Thank you.
Any other questions? So I think it was very nice presentation, Dr. Neil Mehta and Dr. Mukunda. If any other questions comes up, we can always share or email us. And then we have the presentation lined up for this webinar series on April 22nd, 7 p.m. And it's gonna be for telemedicine, and there will be also webinar for the pediatrics. So we'd like everyone to see you again.
Thank you.
Until that,
Thank
good day.
you.
Thank you. Thanks
Thanks.
a lot. Bye-bye. Bye.
All right. Bye.